Good day. I'm Dr. Ian Martin. As one of my last acts as president of the Society for Academic Emergency Medicine, I wish to thank you for participating in our virtual 31st annual meeting. We, of course, had hoped to come together as a community of academic emergency physicians this week, but the coronavirus pandemic had other plans for us all. As I conclude my term as your president, I want to thank those who provided me with immeasurable assistance, counsel, and support this year. They include our Society CEO, Megan Shagrin, the entire SAEM staff, the SAEM Board of Directors, my family, and the Medical College of Wisconsin, where I serve as professor and chairman of the Department of Emergency Medicine. I'm grateful for the trust and support you all placed in me this year, a year marked by great success for our society and by the greatest challenges that we as academic emergency physicians may ever face in our careers. In these brief remarks, looking back, I want to take a few moments to highlight some of the things we accomplished together as a society this past year. And I'd of course be remiss not to mention the impact of the COVID-19 pandemic on academic emergency medicine and upon our lives of late. We've made great strides this past year, firmly asserting SAEM as the voice of academic emergency medicine. SAEM now has more than 7,000 members, the largest number in our history. We had a record number of almost 3,300 attendees at our 30th annual meeting last year in Las Vegas, and we were on track to surpass that number at our 2020 meeting in Denver, a meeting that was, of course, canceled due to the pandemic. As a society dedicated to the advancement of emergency medicine education, we expanded SAEM Test, one of our society's most important products and services. This year, 16,000 tests were taken by more than 11,000 students, literally around the world. Advocacy for our members is an important part of SAEM's mission too. During this past year, through a collaboration with other national emergency medicine associations, we effected the changes we wanted on two major issues. First, we, along with other associations, quashed our future involvement in the Association of American Medical Colleges' flawed standardized video interview pilot project. Our opposition was based on ongoing concerns around the validity, value, cost, and bias in the project. Second, we joined with other major associations in getting the Accreditation Council for Graduate Medical Education to reverse its stance regarding the removal of mandated protected time for core faculty members in emergency medicine. SAEM also launched several important initiatives over the past year. The Equity and Inclusion Committee will launch this week. It was created to advance equity, diversity, and inclusion in alignment with SAEM's strategic priorities. Our main journal, Academic Emergency Medicine, launched an initiative to develop clinical practice guidelines that marry findings from existing medical literature and expert consensus. Known as GRACE, or Guidelines for Reasonable and Appropriate Care in the Emergency Department, the initiative will develop guidelines that address a multitude of undifferentiated complaints that can be found on the tracking board of any emergency department in the country. In July of 2019, SAEM addressed the needs of one of our most important constituencies, vice chairs of academic departments of emergency medicine. SAEM created a new interest group for vice chairs as a forum to collaborate, seek advice, share best practices, and network in a number of areas including education, research, clinical operations, faculty affairs, and business strategy. In my inaugural address in Las Vegas, I discussed the need for greater and more impactful research in emergency medicine medical education. To this end, I am delighted that registration will begin this summer for SAEM's new course, Armed Med Ed, or Advanced Research Methodology Evaluation and Design for Medical Education. Armed Med Ed is set to begin in 2021, and it'll build upon our original Armed course focused on clinical research. The purpose of the Armed Med Ed course is to provide participants who already possess fundamental medical education research knowledge with advanced level skills to design high quality medical education research projects in a mentored environment. Our society also negotiated a long-term contract with our CEO, Megan Shager. Long before the pandemic hit, we thought it important to ensure the stability of our organization for years to come. Now that we're in the throes of a pandemic, we're relieved to know that we've ensured the future of the society. But beyond our society's accomplishments this past year were the unforeseen challenges we faced due to COVID-19. Never in the history of our specialty have we faced a crisis that would overwhelm many of our emergency departments, tax our abilities to test and treat patients with diminishing supplies, and risk our lives every day we come to work. Now, while I just use the word work, the reality is that we physicians in academic emergency medicine don't view what we do as work or a job. As I wrote my farewell editorial on SAEM Pulse, what we have is a calling, a magnetic and all-consuming passion to heal. Even when we're off duty, our physician persona is really never far away. The COVID-19 pandemic has put our specialty front and center for all to witness. Our colleagues from other specialties, our families and our friends, our communities, and now the media see and hear of the life-saving difference we emergency physicians are making to the care of patients during this scourge. You and I know we make this difference every minute of every hour of every day, pandemic or not. We emergency physicians have always been the heroes in healthcare. Fortunately, now the rest of the world can see it too. The COVID-19 crisis has also drawn attention to the intersection of emergency medicine and public health. Our emergency departments often provide the first warnings of health crisis in our communities. In addition to treating the sick and the injured, we are advocates for health and disease prevention. As examples, we routinely screen for suicide risk as well as child, spouse, and elder abuse. Our screenings for HIV and hepatitis C help prevent the spread of these diseases in our communities. I'm really excited that one of our keynote speakers, Dr. Leana S, will be exploring this exact concept in her address, Emergency Physicians and Public Health Providers, the New Pandemicists. Dr. Wen is the former health commissioner of the city of Baltimore and has expertise in both emergency medicine and public health. A troubling aspect of the pandemic is who it's affecting. As you're all well aware, the COVID-19 pandemic has disproportionately impacted our nation's communities of color and those who are economically disadvantaged. It has spotlighted racial and health disparities and structural inequities. While this disease knows no racial or ethnic or socioeconomic boundaries, it does exacerbate and highlight the pre-existing racial disparities and inequities in health outcomes. Inequities in income, housing, jobs, and healthcare access all contribute to the racial disparity seen during this pandemic. COVID-19 has raised our awareness of our need to be more vigilant in addressing these inequities. The COVID-19 crisis has tested the disaster plans at our nation's academic medical centers. Disaster preparedness has always been a part of what we do in emergency medicine. As academic emergency medicine physicians, we often help author the plans in place in our institutions. This crisis has certainly put these plans to the test and have enabled us to identify what is working and where changes are needed. We are the experts in this realm, and it's now recognized and appreciated by our colleagues in the House of Medicine. One of the challenges we'll face as this pandemic continues is to allay public concerns about contracting COVID-19 in the emergency department. While some of our hospitals in large metropolitan areas have been overrun with COVID-19 patients, hospitals in many other parts of the country have seen dramatic declines in the number of patients seeking emergency care. The decline can be attributed to a number of factors. Stay-at-home orders have led to fewer cars on the street and thus fewer car crashes. Patients are seeking medical care through virtual visits and with physicians and advanced practice providers. With the economic uncertainties and increased unemployment, some patients are prioritizing other things over doctor's visits. And some don't seek emergency care fearing they will be exposed to COVID-19 if they come to our facilities. We need to get the word out that we've created an environment in our emergency departments that is safe for everyone. As we're focused on treating the victims of this pandemic, we must always remember that we are also the teachers of the next generation of emergency physicians. The residents in our departments are facing unprecedented challenges. They are developing their skills as physicians while treating patients with a potentially deadly respiratory illness about which much remains unknown. Our approach to medical education has changed during this pandemic. In the future, I hope to see SAEM spawn research into effective alternate methods of teaching during time of pandemic. While many academic medical centers have hibernated research during this scourge, the SAEM Foundation just announced that it will be awarding up to $50,000 in grants of various sizes for COVID-19 related investigative research. And while on the topic of our foundation, this past year, it awarded almost $670,000 in research grants, the highest amount ever. Now, I wish I could promise you that a vaccine for COVID-19 will be developed in the coming months and that mass inoculations will lead to the end of this pandemic. Unfortunately, that's unlikely to happen. We can expect to be dealing with waves of patients stricken with COVID-19 for the next year and perhaps beyond. And as we deal with this crisis, we need to be prepared for the inevitability of faculty, fellow, resident, and staff burnout, the likes of which we've never seen before. COVID-19 is exacting a physical, economical, and importantly, psychological toll on us all. So we need to take care of ourselves and of one another. One thing that the COVID-19 crisis has shown the world is our unconditional commitment to our patients and to our calling. The simplest description of what we do is that we save lives, or at least attempt to. As much of the country's population is shuttered in their homes with their families, we emergency physicians stand on the front line providing life-saving, time-sensitive care to the victims of this global pandemic. Rightfully so, our fellow Americans recognize us as heroes. I've never been prouder than I am today to be a physician, especially an emergency medicine physician, and I hope you feel the same. So in closing, I want to thank you all, the leaders in academic emergency medicine, the senior, mid-career, and junior faculty members in our field, and the fellows, residents, and students who will carry the mantle for academic emergency medicine in the decades to come, for your commitment to our specialty and your support of the society. You all are, in the truest sense, heroes. It's now my pleasure to pass the torch to Dr. Jim F. Holmes, 32nd president of this great society. Dr. Holmes is well prepared to lead us through the still uncertain and challenging times ahead, as well as to guide us when the clouds of this pandemic clear. Dr. Holmes is professor and executive vice chairman of the Department of Emergency Medicine at the University of California, Davis School of Medicine in Sacramento. After receiving his undergraduate degree from Auburn University, he earned his doctorate of medicine degree from the University of Alabama, Birmingham School of Medicine, and his master of public health degree from the University of California, Berkeley School of Public Health. Dr. Holmes trained in emergency medicine at the University of California, Davis Medical Center, where he also served as chief resident. His research is focused on the initial evaluation and treatment of injured patients, with a particular emphasis on injured children. Dr. Holmes has additionally worked to advance emergency medicine globally. He has provided guidance for a multinational Asian research study on trauma and supported the training of emergency medicine providers in Vietnam. Dr. Holmes helped start the emergency medicine training program in Fiji, in fact. Finally, Dr. Holmes has devoted much of his career to training junior investigators. He created the UC Davis Emergency Medicine Research Fellowship, which was funded in part by an SAEM Institutional Research Training Grant. As a demonstration of his impact as a mentor, 3 of his program's graduates have gone on to receive SAEM's Young Investigator Award. Dr. Holmes also served as co-director of the UC Davis Emergency Medicine K-12 Research Training Program. He is currently director of the UC Davis Clinical and Translational Science Center's KL2 Research Training Program, one of only 2 emergency medicine physicians in such a role. Ladies and gentlemen, I present to you your new president, Dr. Jim Holmes.
Thank you very much, Dr. Martin. Good afternoon or morning to all SAEM members and guests attending the SAEM20 virtual meeting. I want to thank everyone for joining in this time of most unusual circumstances. It is my great honor, and I am certainly humbled to be before you. You have to forgive me, as this has been a long journey, and I would like to thank a few individuals. I think back to my first SAEM meeting in May 1996, which quite ironically was in Denver, Colorado, and many people have influenced my career over the last 20 years. First, I would like to thank my parents, who had originally planned to be in Denver before a series of unfortunate events, including COVID, prevented their attendance. Second, I would like to thank my wife, Cindy, and my kids, Caitlin and Audrey. They have been incredibly supportive of my work over the years, and my children actually gave me my current haircut in our backyard just a few days ago. I think we all hope that they go back to school soon. I would like to especially thank Megan Shagrin, our CEO, and the SAEM staff who had to take all the work and planning previously done for an in-person meeting, change gears, and in just 2 short months, put on a virtual meeting. This is something none of us expected, but the staff and our members have done it and done it remarkably well. Some outstanding content awaits you in this virtual meeting. Watch it. The SAEM staff is remarkable. I would have asked you to introduce yourself and meet them when you see them in the hallways and meeting rooms in Denver, but that will have to wait until next year in Atlanta. For now, please just thank them virtually. Finally, I am fortunate to have had great mentorship throughout my career, both within and outside emergency medicine. Mentorship is a key to academic success and perhaps the most important factor. And I must thank Nate Cooperman, who's been an incredible mentor and helped me in many, many ways over the years. I am also fortunate to have served with some really outstanding prior SAEM presidents. I've learned a tremendous amount from all of you and am indebted to you for your leadership and your contributions to our society. I must specifically thank Alan Jones, who as SAEM President-elect called me up and asked me to run for the SAEM Board of Directors. At the time, I would never have thought to run for the SAEM Board. Often people do not view themselves for positions that they could be successful in. Never hesitate to suggest to someone to go after something they would be good for. Encouragement from others is often all that is needed to spur a successful career path. I want to also thank Ian Martin for his leadership this past year. It has been a pleasure watching you advocate for academic emergency medicine. You always sought advice and developed consensus for those difficult decisions. I can only hope to be half as good of a president as you have been. Finally, my sincere thanks goes to all the SAEM board members whom I have worked with over the years. My thanks and respect to all the many providers who have cared for patients during this pandemic. Obviously, some of us have been impacted more than others, but all of our lives have been disrupted in some fashion. We have had numerous healthcare providers get sick with COVID, and unfortunately, some have paid the ultimate price. Our experiences shape who we are as emergency physicians. I am inspired by the care provided by those in New York, New Jersey, Chicago, New Orleans, Los Angeles, Washington, and the many other places significantly impacted by COVID. In too many instances, providers sacrificed their safety for their patients. I was further moved by the commitment made from those who were less impacted. Many centers volunteered physicians to go to the most affected locations to help their colleagues and the patients who need care. SAEM has already convened 2 very successful COVID grand rounds, with providers in New York and New Orleans presenting their experiences, and we will continue to develop pertinent, up-to-date content for our members, not only for COVID, but other important issues as they arise. SAEM continues to grow, and we will not let the current pandemic hinder our mission. We have nearly 7,000 members. The SAEM20 meeting set records for all types of submissions, from didactics to abstracts, and we were on track for the largest SAEM meeting in our history. We will continue our growth. Our staff has worked diligently to ensure an outstanding virtual meeting, as well as continuing our regular services to provide academic emergency physicians a home and a voice. Academic emergency medicine is a community, and SAEM is our home. Because of you, our members, SAEM will advance emergency medicine education, research, advocacy, and professional development. Much like medicine as a whole, academic emergency medicine has challenges ahead. Beyond the obvious issues of COVID in our emergency department, but issues of faculty protected time, medical student and resident education, physician wellness, diversity in our field, and research dollars, just to name a few. SAEM has and will continue to advocate and help advance our mission and address these issues. There is strength in our shared voice, and we believe through SAEM that we can improve care for the millions of people when an unexpected emergency occurs. We have stood united to face the current pandemic. We will continue to stand in solidarity to advance emergency care. There is work to be done and discovery to be made. Let me highlight just some of the recent SAEM offerings for our members. I am pleased to announce the new SAEM Equity and Inclusion Committee that formally begins this week. The new committee is a product of the Diversity and Inclusion Task Force and will work closely with both the Academy for Diversity and Inclusion in Emergency Medicine, ADIEM, and the Academy for Women in Academic Emergency Medicine, AWIM. This committee will continue SAEM's commitment to address disparities not only for our patients, but for our medical students, residents, fellows, and faculty. Just 3 short years ago, SAEM started ARMED, a state-of-the-art research course targeting promising junior investigators and taught by leading experts in emergency care research. Based on the success of ARMED, we are proud to launch ARMED MedEd. ARMED MedEd fills a much-needed gap to train young investigators in medical education research. Thanks to all, especially Wendy Coates, for developing this much-needed course. I am also pleased to inform you that we completed the first wellness survey of our membership. We know that physician burnout disproportionately impacts emergency providers, and limited evidence exists for those of us in academic emergency medicine. Over 1,000 of our members responded to this survey, providing insight into issues related to academic emergency providers and wellness. I look forward not only to the results, and you will hear some of these initial results at the Friday plenary abstract session, but also to the interventions generated in the future. The current pandemic has added additional stressors to our already high-intensity jobs, and certainly it impacts our well-being. Remember, you do not have to face this alone. If you need help, please reach out to one of the many sources available, including your SAEM colleagues. Since the founding of SAEM, we have made great strides in emergency care research, but more is needed. SAEM recently concluded a task force to identify research needs for its members for the next 10 years. Recommendations from that task force are being implemented and will continue to be implemented to improve our members' ability to conduct discovery. SAEM offers its members many opportunities for professional development and career advancement. Regional meetings, 2 journals, a newsletter, a chair development program, research training courses, numerous academies, committees, and interest groups are just some of the many offerings. SAEM has something for everyone at all stages, from medical student to full professor, and the opportunities you need to advance your career are here. Take a look and take advantage. We do not know what our future holds, but there will be challenges ahead that we must face. We may continue to see COVID outbreaks across the United States. We should, however, remain diligent and prepared. We must shape the future of academic emergency medicine that emerges from this pandemic through a thoughtful effort. You are the ones to address the challenges that will come in the next week, month, and year. I am confident that you will solve these problems that we face. I promise that we will do our utmost to make our society stronger. I am incredibly honored to be the SAEM president and look forward to working with everyone to advance our specialty and navigate through this time. I hope everyone enjoys the new format. I look forward to a time when we can meet face to face and share our experiences. Stay safe and stay well. Thank you.
Good day. I'm Dr. Ian Martin.
1 minute out, 1 minute out. Thirty seconds. $15, 10, 9, 8, 7, 6, 5, 4,
Good afternoon, and welcome to the Society for Academic Emergency Medicine SAEM20 virtual meeting. I am Dr. Jim Holmes, SAEM President. For those of you joining us for the first time, SAEM is the premier international organization representing researchers and educators in emergency medicine. In our work, SAEM promotes and facilitates scientific discovery, educational innovation, and the professional and leadership development of our members. Today, we are proud to bring you the COVID-19 keynote address entitled Emergency Physicians and Public Health Providers, the New Pandemicists. During the presentation and during our question and answer session, you will hear from Dr. Leana S, visiting professor of health policy and management at the George Washington University Milken Institute School of Public Health, where she is also an adjunct associate professor in the Department of Emergency Medicine. Dr. Nguyen was the former health commissioner for the city of Baltimore and a frequent commentator on CNN, MSNBC, and BBC. She will share her knowledge and views both from public health and emergency medicine perspectives on the COVID-19 pandemic, providing along the way guidance and insight that will likely prove invaluable to the rest of us as we care for our patients in our own communities. During the presentation, you may submit questions for the presenters by clicking the Q&A button in your Zoom menu interface. Questions that are upvoted will be prioritized during our questions and answer session to start immediately after Dr. Nguyen's presentation has concluded. To kick things off, I'd like to introduce Dr. Rich Rothman, SAEM's COVID Planning Chair, to provide the opening remarks for today. Dr. Rothman is the Executive Vice Chair in the Department of Emergency Medicine and Professor of Emergency Medicine at Johns Hopkins Medicine. His research program focuses on the interface of emergency episodic care and infectious disease surveillance, diagnosis, and treatment, with research on varied commonly occurring ED conditions, including pneumonia, skin and soft tissue infections, sepsis, HIV, STDs, influenza, and now COVID. He has particular expertise in development, translation of rapid and novel molecular diagnostics. At Johns Hopkins, he works with an interdisciplinary research team, which includes investigators from emergency medicine, microbiology, infectious disease, and public health. Currently, Dr. Rothman serves as principal investigator and co-director for the NIH-NIAID Center of Excellence for Influenza Surveillance and Research, as well as a lead on a BARDA Health and Human Subjects Cooperative Agreement to study new approaches to advanced therapeutic trials for pandemic response. Dr. Rothman was also one of the founding members of the SAEM Group, a national network of academic emergency departments focused on research, practice, and policy related to emerging and transmissible infectious disease. Welcome to you, and thank you for being here, Dr. Rothman.
Thank you, Dr. Holmes, and thank you to SAEM for hosting today's keynote address. As Dr. Holmes mentioned, our keynote address is Dr. Leana Wen, who's a visiting professor of health policy and management at George Washington University Milken Institute of Public Health. She's also a distinguished fellow at the Fitzhugh Mullen Institute for Health Workforce Equity. Previously, as Dr. Holmes mentioned, Dr. Wen served as Commissioner of Health for the City of Baltimore, as well as the President and CEO of Planned Parenthood. In 2019, Dr. Wen was named one of Time Magazine's 100 most influential people and as Modern Healthcare's 50 most influential clinical executives. Dr. Wen earned her medical degree from Washington University School of Medicine and her master's degree at the University of Oxford, where she was a Rhodes Scholar. She then completed residency training in emergency medicine at Brigham and Women's Hospital and at Mass General Hospital. She's the author of dozens of scientific articles and has been an op-ed contributor to the Washington Post, National Public Radio, and the Baltimore Sun. She's also regularly featured on CNN, MSNBC, NPR, BBC, and PBS. Today, Dr. Wen will be sharing her perspectives from the vantage of a practicing emergency physician and a public health leader during the current pandemic.
Wonderful. Thank you so much. And good afternoon, everyone. I am really honored to be here today, to be invited to keynote today's session at SAEM, and especially during this time this year. I first had a conversation with Dr. Jim Holmes and Ian Martin a couple months ago about this talk. And I remember them both saying, we've never been prouder to be emergency physicians than right now, that we've always known about how important our work is, and now the world sees what it is that we do. And I think COVID-19 has brought our work and the importance of it, and the importance of being frontline providers to the public. And I am really grateful that others can see the tremendous efforts that all of you put in now and every day, and also the sacrifices that you make in service to our patients. And so I'd like to begin today by first thanking our president, Dr. Jim Holmes, our immediate past president, Dr. Ian Martin, the entire SAEM board of directors and staff, of course, Dr. Rich Rothman as well, for your work in partnership, certainly here in Baltimore. And I want to thank all of you. I remember attending my first SAEM conference as a resident, and I've always appreciated the work of academic emergency medicine. And I can't tell you what a great honor it is to be back with you, to be with the people that I train with and learn from, those who are involved in training the next generation, and those also who are in the next generation too. I have the utmost respect for the work that all of you do. So the title of my presentation is Emergency Medicine, or Emergency Physicians and Public Health Providers, the New Pandemicist. And I think we can go to the next slide, which shows this. And what this highlights is that COVID-19 is this intersection of the two fields that have been a part of my life and many of our careers, which is these two fields of emergency medicine and public health. And by the way, in case you're wondering about what all my slides are going to look like, they will all look like this. I have 8 of them in total, with very brief words and no pictures on them. So hopefully we can keep you entertained through Zoom. I wanted to start with this intersection because I went into emergency medicine, I think, for many of the reasons that we all did. For me, coming as an immigrant to the US and growing up in underserved areas, I never wanted to be in a position where, as a physician, I would ever have to turn anyone away because of ability to pay, because of where people came from. But it was also in the ED that I realized the limitations of our work as well. I remember this one patient in particular who I kept on seeing over and over again. And all of you know these patients who come in so many times that we can recite their CBC. We know what their last CT scan showed because we were the ones that performed it just a couple of days ago. And this was a woman who came in day after day seeking help for her addiction. She was only in her 30s, but she certainly seemed much older. We all knew that what she needed was help for her addiction. And yet we also knew that by the time we called the social worker, by the time the social worker called around looking for beds, the soonest she might be able to get in anywhere was possibly was at best a couple of weeks, maybe even longer. sometimes this patient would lie to us and say that she was suicidal, even though she wasn't, because she knew that it would buy her some additional time for us to call a psych consult. And I always thought about how tragic it is that our patients feel like they have to lie to get the care that they desperately need. In any case, I remember this patient coming in one last time. She came in that morning and we referred her to see someone as an outpatient and found her an appointment in a few weeks' time. And then she came in on my same shift. And this time she had overdosed and we were unable to resuscitate her and she died. And I remember all of us looking into her chart and counting the number of visits that she had had in our ED. And over the course of a couple of years, it was over 100 times that she had been to see us in the ED. And our system had failed her time after time until it eventually cost her life. I think all of us can tell stories like that of how, despite our best intentions, our system is what's failing us. And as much as we want to help patients in the setting of the ED, there's something much bigger that's at play. And it's for that reason that I went into public health, thinking that it might be a way for me to influence that broader system. And so I ended up having my dream job, as you heard from Dr. Rothman, Dr. Holmes, which was that I led the Baltimore City Health Department as the commissioner there for 4 years. And in that role, actually, I also saw the integral role of emergency medicine. Because, for example, I saw how much there are policies that sound really good on paper, but when it comes to actually what's implemented on the front lines for our patients, that's often where it falls apart. And I'll give you some examples of this too. And I think it's actually working in public health too that I gained an even greater appreciation of the work that we do in emergency medicine. That for us as emergency physicians, we are the front lines in so many ways, the front lines of patients coming in. We're also the front lines of seeing the problems, these systemic challenges that we face. And we're also, incidentally, the first ones to see problems coming too that are the pandemics. In the case of COVID-19, it was the frontline physicians in China, in Italy, and here in the US too, who are sounding the alarm about this new virus and about the devastating effects and harm that it can cause. And so I just have such a deep appreciation for the work that emergency medicine and public health do hand in hand. And so what I want to do in this talk, the next slide, is I want to go over 5 lessons from the front lines that I learned drawing upon the experiences in emergency and public health, particularly focusing on this time of crisis for our country. So lesson number 1 in the next slide is that we should do what we can now. Now, those of us in emergency medicine know that we do not have the luxury of time or hindsight, that a patient comes in extremis, we may have extremely limited information, but we have to act now. We have imperfect information, but if we don't act now, waiting and doing nothing, of course, is a decision and an action too. It's always easy, I think, to be on the other side of this and to look at the decisions that we made and to second guess that decision, but we do the best that we can. But as much of a challenge as this is also what we're good at. I want to give you the example in public health too, that this is also the same lesson that we can apply in public health. When I first started my job in Baltimore, when I was first appointed was December of 2014. And we were facing an escalating number of deaths from opioid overdose at that time. And I turned to my team and we brainstormed and we worked with our partners to think about what it is that we can do. I mean, stopping overdose and treating addiction is a complex problem. And so many people came up with these multi-pronged, multi-system solutions that, yes, they are important, but we also cannot wait for all these things to occur. So what we did was to say, let's start with what is in our control right now. And what was in our control was naloxone, Narcan, which all of us have worked with so many different times. I mean, working in the ED, I've resuscitated patients, as all of us have, with Narcan many times, and have seen how someone who would otherwise be dead would be walking and talking within seconds of getting this medication. And so in the wake of escalating numbers of people dying, we worked with the state legislature and within a few months actually got the state legislature to allow me to issue a blanket prescription for naloxone to every single resident in our city. Now, I knew this was the right thing to do, but I will say that writing your NPI number, printing your NPI number and signature on 620,000 prescriptions was something that did give me a little bit of anxiety. But that was an important first step. We were able to get that blanket prescription out so that essentially naloxone became over the counter. And this was back in mid 2015. We also ended up training the trainers. We trained community organizations. We deployed people on our needle exchange vans and community health workers. And within 3 years, had done nearly 30,000 trainings. And by the time I left my job in Baltimore 4 years later, everyday residents had saved over 3,000 lives of fellow residents in our city. Now, I talk about this because, of course, there were other things that we ended up doing too. We also ended up having a hub and spoke model for addiction treatment. We started a stabilization center, which is the beginning of a 24/7 ER for addiction and mental health. That was actually a pre-hospital diversion from the ED for patients who needed addiction and mental health support. We were able to do all of these things in time, but we also had to start somewhere. Perfect cannot be the enemy of the good, and often waiting is not an option. That's what we know from emergency medicine, and I think is a lesson that's deeply embedded for us in public health too. That sometimes you do want to wait for all these factors to converge, and I think in public health as well, you look at the social determinants of health. You know that so many different factors also affect how long someone lives, how well someone lives. I mean, all these are important to address in time, but I also strongly believe that we need to find the intervention that's in our power and do what we can now. And I think that these are the same lessons that we see in the COVID-19 crisis as well, that we've seen when patients come into our EDs, that we roll up our sleeves and we treat them. We don't know what the ideal treatment is when this first started. This is a new virus. How would we know? But we know our training, we do the best that we can, and we do our part to take action and do it now. Now, that said, and I'll go on to lesson number 2, it doesn't mean that we stop. Lesson number 2 is that we still evaluate, innovate, and improve constantly. Again, I think this is second nature to all of us in emergency medicine, but maybe needs to be spelled out to those who are not familiar with our field. But we've seen this with COVID as well. We start somewhere and we treat our patients with the best information that we have at the time. But we're constantly evaluating as well. We're constantly looking for new treatments. The idea that patients can get better oxygenation prone, for example, or that patients with COVID can tolerate lower oxygen saturation, and we will not need to intubate them, to intubate some patients who can do just as well or even better. I mean, these are all things that we've just come up with in the last couple months. But I look to the ingenuity and the curiosity, I think, of emergency physicians and the willingness to try new things as the reason why we've been successful thus far in combating this crisis. I think we in emergency medicine, given our training, we're comfortable with not knowing and trying and improving. And actually that change, as uncomfortable as it is for many other people, we know is important. And in fact, is the bedrock of emergency response and good public health practice to be able to look at what we're doing and adjusting accordingly. I'll give you an example from our time in Baltimore as well. There was a program in our city called Be More for Healthy Babies that aimed to reduce infant mortality and was a public-private partnership involving over 150 hospitals, community groups, religious groups, and others that aimed at one goal, which is to reduce infant mortality. Well, you all know about infant safe sleep, that infants should be put to sleep alone in a bed, on their back, alone on the back in a crib. Don't smoke, no exceptions. I have an infant right now, and I think it's lack of sleep that's making me mix up my ABCs of safe sleep myself, but ABCs of safe sleep: alone, the back, in a crib, don't smoke, no exceptions. And we taught the ABCs of safe sleep and had all these community health workers also visit people in their homes, social workers visit moms in their homes, and even hand out free cribs. What we were finding, though, was that still there were many infants that were not abiding or that were not conforming to the ABCs of safe sleep practice. And in fact, there were still infant deaths as a result of unsafe sleep practices. And so we sent our community health workers to visit women in their homes and see what's going on. And what they found was that so often the babies were still sleeping on a couch, co-sleeping, et cetera, in other unsafe environments. And so we asked, what's going on? Because we're giving out these free cribs. Well, it turns out that when the home visitors went to the homes, they found that the cribs were still in a flat pack and never opened. And the reason was that many of the families did not have the tools or knew how to assemble the crib. Now, that was something that was actually an easy intervention once we figured out the cause, because then in addition to sending the free crib, we could send someone out there at a time when we could do home visits safely, but we could send people out there into people's homes to make the crib. And that was a simple intervention that ended up resulting in a huge change in behavior, only because we knew about the importance of constant reevaluation. And by the way, as a result of teaching the ABCs of safe sleep, as a result of all these home visiting practices, of ensuring in our city that every pregnant woman who is on Medicaid ends up getting triaged to levels of care, and they would get a home visitor, a nurse, a social worker, etc., to visit them in their homes during their pregnancy and postpartum. As a result of all of these interventions, we were able to reduce the infant mortality in our city by 38% over the course of 7 years. And we also closed the disparity between Black and white infant mortality in our city by over 50%. But again, only able to do that because of constant reevaluation. I think this brings up another point in this lesson as well, that a policy alone is not enough. We need practical intervention as well, and practical implementation as well. When I talked about the naloxone policy, it wouldn't have been any good if I just issued a standing order, but no one knew about it. We also had to be aggressive about educating people in our city about naloxone, doing the trainings, meeting people where they are. We went to bus shelters, we went to housing units, we went to restaurants and bars to teach people about it. Because if you don't know about it, if the pharmacies aren't stocking naloxone, I also hired someone whose sole job it was to go to pharmacies and talk to pharmacists about making sure to stock different formulations of naloxone and fulfill these prescriptions. Without that practical on the ground work, implementation, the policy alone is not enough. And I think that, again, is a lesson about the importance of constantly evaluating, innovating, and improving. Lesson number 3, to the next slide, is that we also draw upon our training. A few months after I started in my job in Baltimore was the death of Freddie Gray, an unarmed African-American man who died while in police custody. And then right after that, there were riots that erupted across Baltimore. I was one of the leads in our city as the head of an agency. I was one of the leads on handling civil unrest. And you know what? There is no playbook for what you should do. What is the public health measure that you implement in the case of civil unrest? But my team, we knew what to do. I had an exceptional team then, including Dr. Jonae Caldoun, another emergency physician who is now the health director in the state of Michigan. And she and I and our team, we knew how we would handle things as emergency physicians. We knew about triage, for example, that life-saving issues have to come first. And so while we saw all these images of burning cars and people throwing bricks, and there was fear about really not being able to get people to care, we knew that our priority had to be getting people to hospitals. It had to be working with our local hospitals to ensure that staff could get there safely, that patients could get there safely, that ambulances still have a route to follow to pick up patients to go to the hospitals. We then had to figure out in the days to come what happened with patients who are on chemotherapy and dialysis. When their clinics closed, how could we get these patients who had urgent treatments to get their care? We followed protocols. We drill for this purpose. We understand our incident command structure. We've practiced this. We know what to do. We also understand the importance of clear communication, just as when there is a patient who's coding in a case where there is a city that's in crisis. We also understood that there has to be one point of contact, one central command structure, and that there is no such thing as over communicating. In those first initial hours, we actually had hourly calls with all of our hospital partners, and then tuned it down to every 4 hours, every 12 hours, etc. But that's what we had to do. There, again, no such thing as over communicating in these times. We also knew about meeting people's needs and doing what it takes. There were at least a dozen pharmacies that were burned down or closed in the wake of the unrest. And initially, I heard comments like, well, what's the big deal? Because there are other pharmacies in the city that people can go to. That's fine for you and me. We can write our own prescriptions and transfer these prescriptions and drive to another pharmacy. But imagine if you're an 80-year-old who's dependent on oxygen, who's in a wheelchair, and who needs Medicaid transportation, and now that's shut down. And your one pharmacy is closed and you don't even have a phone. How are you going to get your prescriptions to be filled? And so we ended up setting up a 24/7 medication access line for people to call, and we would get the prescriptions to them. For seniors who are in buildings that did not even that were in particularly affected areas, we went door to door in these areas to ask about what needs people had. And when they came up with needs like banking and food and supplies, we ended up getting these supplies for people and delivered to their homes. And I give this example because this is an example of just what we know how to do in emergency medicine. We know that so many of people's needs are not immediately reflected in what one might expect, that you have to go to people, ask them, and then to meet people where they are. The unrest itself was new. The idea of handling public health during civil unrest was new, but we knew what to do. We've trained for this purpose. We need to trust our training because this is frankly the work that we know how to do every day with confronting unknowns and thriving in the face of difficult challenges. One more example of this, I want to take you back to residency. I was a fourth-year resident in the spring of 2013, working at Mass General Hospital, when we heard over the loudspeakers that there were bombs that had detonated at the finish line of the Boston Marathon. And again, we all sprung into action and knew what to do. I look back at this and, I think so many of us, it was not just the Boston Marathon bombings. I mean, all of us in some way have been involved with these mass casualty events. I mean, it's tragic and heartbreaking. And what we're living through with COVID is so heart-wrenching on so many levels. But this is what we are trained to do. It doesn't make it any easier, but it does make all of us as emergency physicians experts in doing what's hard. We are seeing tragedies now in the wake of COVID in a way that none of us could have ever imagined possible. But we are emergency physicians. This is what we are trained to do. This is what we are honored to do in service to our patients every day. And so draw upon our training and recognize how it's prepared us for these challenging moments now and in the future. Lesson number 4, to the next slide, is that we find interventions when we can. There's a parable in public health that's about 3 friends who are walking along a river that's flowing very quickly. And they begin to see that there are children floating by, and these children are drowning. So the first person jumps in and starts rescuing the children one by one, but more and more kids start going by. The second person starts running upstream and sees that there's a dam and tries to repair the dam, because if you can repair the dam, that's one way to stop these kids from drowning as well. The third person keeps on running, and the first 2 shout after him, "Hey, where are you going? Help us now." And the third person says, "But I'm trying to see who's throwing in these kids in the first place." Now, that parable is often told as an example of going upstream. The purpose of public health, or one goal in public health, is to go as far upstream as possible, with the idea that if you can intervene really early and change the trajectory of somebody's life really early, and you're able to prevent so many other things downstream that would have to happen. We took it upon ourselves to do this in Baltimore. One of the programs I'm the most proud of, for example, is a program that seems very simple. That's called Vision for Baltimore. It provides free glasses and eye exams to every child who needs it in the city, which seems, again, very basic. But there was a study done right before I got to Baltimore that found that up to 10,000 of our school children needed glasses, but were not getting them for a variety of reasons. They were not getting the screening, they had insurance issues, their parents never knew about their screening results, and so forth. And so we partnered with Johns Hopkins, Warby Parker, a number of other organizations to literally do screenings in schools and eye exams, and then free glasses provided by Warby Parker. And I remember there was a PBS crew actually that came to do a documentary about our program. And I think the producer was hoping to capture this moment when these little kids were getting their glasses for the first time. And I think they were hoping to capture the aha moment of, wow, now I can see. Well, they asked this one girl who had just chosen her little pink frames for the first time, and they asked this girl if she sees a difference when she puts on her glasses. She was not very impressed, and she said no. So then the producer asked her to read something without her glasses, which she squinted at and really had trouble reading. And then she put on her glasses and read the same thing flawlessly with no pauses. And the producer said, "Do you see any difference?" And I think was, again, waiting for this aha, thank you moment. And the girl was still not impressed, and she said no. But I was watching, and there was one of our vision screeners who had worked at the health department for over 20 years. She was watching everything unfold from behind the scenes, and she had tears running down her face. I think because she saw what a difference something as simple as a pair of glasses can make. And it could really make the difference for this girl between potentially even advancing grades and not, and that it could really change the trajectory of her life. Now, I'm not saying that glasses are a panacea to education, but I think it's one example of how something small can make a difference, how this upstream example is something that we should do as much as possible. But I'll add too that for us in emergency medicine, we also have to intervene midstream and downstream too. Because if we are one of these friends who are running along stream, sure, there is the role of somebody who is trying to go far upstream to figure out who's throwing in these kids. But if we see a child who's drowning now, so to speak, it's also our job to intervene now. Someone who is shot, ideally, we could have prevented that gunshot in the first place. But if they're shot now, we have to save their life, but we also have a chance to intervene to make sure that they don't get shot again. And I say all of this because I think so often when we talk about public health, we think about things that are really far upstream, but we should not forget the importance of these midstream, downstream interventions as well, and how something that seems like a very small intervention is actually what will make a huge difference at the end of the day. In the times of COVID, I think so much about patients being alone. And, it's something that, again, I don't think any of us could have really imagined. The idea of patients being critically ill alone, even dying alone. And I also think about the small acts that for some patients really mean the world. The small act of connecting someone over FaceTime, of using your own phone in some cases to do so. When family members cannot hold someone's hand, again, I can't even imagine this happening, but that's what we have right now. And if that's the situation that our patients are in, then the small acts that we can take, some of them are big acts, some of them are saving someone's life and helping them to recover. But the seemingly small acts of connecting someone on the phone to say goodbye one last time, that matters too. It's May, and we just had Mother's Day. My mother died about 10 years ago from metastatic cancer. And I remember the day that she passed away. We were in a very busy hospital ward, and we did not have our own room. And she was about to pass. And I remember there was a nurse who found a curtain because the curtain had actually been broken. She found a piece of curtain and drew the curtain closed and stood in front of that curtain as a way to give us privacy. I will remember that act, that seemingly small act, forever. And I think that's the kind of difference that all of us make in our patients' lives every day too. Let me go on to the fifth lesson. And the fifth lesson is to make the invisible visible. There's a saying in public health that public health saved your life today, you just don't know it. And that is the case with public health, that so much of the time, the work that we do is invisible. It's behind the scenes. And in fact, we are successful when something did not happen. We may do hundreds of restaurant inspections in order to prevent the one case of foodborne illness that you never knew about because it never happened. The interventions that we have to abate someone's home from lead means that children are never lead poisoned in the first place. And actually, you could say the same thing about emergency medicine too, that so much of the work that we do is behind the scenes. by the time that someone arrives on the floor in the ICU, we've done all these interventions, and they're all kind of behind the scenes because not everyone is aware of all the work that was put into for someone to be stabilized as they are. Well, I think that in the time of COVID, the world is now seeing the work that public health is, and also the work that emergency physicians do every single day. And I think about the work and the sacrifice that everyone is making. And by the way, I just have to say, some of these sacrifices that emergency physicians are making shouldn't have to happen. I mean, the fact that we are, at least certainly at the beginning of the outbreak, running out of PPE. I mean, I had my classmates from residency email around about what the best way to refashion masks were, how many times you could sanitize a mask, whether we could ask other our friends and family to go to Lowe's and Home Depot to buy masks, or figure out home improvement or fashion supplies from home improvement materials, or even go so far as to buy rain ponchos and think about how garbage bags and ski masks can be repurposed. I mean, I know that that's what we had to do, and I'm glad that we were able to do these things and that other people have stepped up to help us at this time, but none of this should have happened. It is actually totally unconscionable that anyone is put into a position where we're trying to protect our patients and we're not allowed to do so. As in, we go into this field knowing that we'll be sacrificing a lot, and we go into this field to gladly serve our patients, but we should not have to sacrifice our own health and well-being. Anyway, I'm going to get off my soapbox about this, but just know that this is something that is just totally unacceptable and should really have never happened. But I think as a result of the lack of PPE, as a result of all the issues that we're facing with overcrowding and lack of ventilators, supply issues, and others, we have really heard emergency physicians speak up with clarity and purpose. And in these times where there is rampant disinformation, and frankly, a lot of myths and misunderstanding and unclear messages coming out, this is not a political talk, I'm just saying, in general, this is a time of a lot of misinformation. Our voice is more important than ever. And it's even more important for all of us to speak with that clarity and purpose, and with urgency, compassion, and action. So I'm going to end today with a quote by one of my heroes, the late Representative Elijah Cummings, after whom my son, my older child, is named. Congressman Cummings liked to say that the work that we have ahead of us is bigger than us. It's so much bigger than us, that it's about our children and about the generations yet unborn, that our children are messengers to a future that we will never see, and that what we do right now is for them. And this is what we do every day. We focus on our patients, we save lives now, but we also know that it's about safeguarding health and well-being for generations to come. Back to the comment that I first referred to when I first talked to Dr. Holmes and Dr. Martin, you can always count on emergency physicians. We're always proud to be emergency physicians. We're proud also to be in academic emergency medicine because we're serving our patients and training the future generations. We will always be there, no matter what, in service to our patients and our communities. We as emergency physicians, we don't wait for others to act. We are leaders and we take action now. We as emergency physicians, we don't just talk about service. We're on the front lines serving every day. And we as emergency physicians, we are not waiting for the cavalry because we know that the cavalry is not going to come, that we are the ones that we have been waiting for. So thank you, Dr. Holmes, and the entire SAEM leadership for your dedication. Thank you, everyone, for your exceptional work today and each and every day. And I applaud you, I celebrate you as I fight together and serve together alongside you. Thank you.
Thank you very much, Dr. Nguyen. And thank you again for this timely and insightful and motivational presentation. In a few moments, we will answer questions from the audience. As a reminder, for those who are attending the live session, please send your questions in via the Q&A pop-up window by clicking the Q&A button in your Zoom menu interface. We will try to get in as many questions as possible in our remaining 15 or so minutes. So while the questions are coming in, I would like to ask Dr. Nguyen, what advice would you have for trainees who are interested in policy and advocacy, especially in the current environment?
I appreciate the question and want to say first off that I think a lot of people will answer this question or will think about this question in terms of politics. And certainly running for office is something that you could do if that's something that you want to do. But I think for the majority of us who want to do policy and advocacy, running for office is not necessarily what we might want to do. And it seems like a pretty high bar just to be involved in policy and advocacy. So I would say there are many other ways to be involved. I would also not necessarily just think about the national level. I think often we think about national level. And again, I think there are many ways to be involved that way, through SAEM, through ASAP, through AAM, through AMA. I mean, there are many organizations, progressive organizations, mainstream organizations, many ways to be involved in national policies if you want. But so much is happening on the local and state level. And I would advise for everyone to be involved with your local and state medical associations if they exist, and are active. Also to be involved with your local health departments, to get involved with local nonprofits that may really need your voice. And again, right now during these times, your voice is so critical. Don't turn down opportunities. I think this really applies to trainees. You know, when I look back at my training, the opportunities that turned out to be the most important in my life were opportunities that I wouldn't have necessarily anticipated and actually might have turned down. But I did not say no really to anything during my training. And I think as a result had wide exposure, and also so many of the incredible mentors that I met as a result are because of these opportunities that I didn't say no to. So don't turn down opportunities, try it and see. I would also advise to find your voice, which is something that may take some time. You may not know if you're most comfortable with the voice that speaks from the patient perspective, that speaks as a physician, or that delves more into policy and politics. There are no wrong answers here, but you have to find the best fit for yourself. And I would say, finally, to not be afraid to do bold things, to take bold action, knowing that sometimes these things don't work out. Certainly in my career, there have been jobs and opportunities that did not work out nearly as I expected. But as Winston Churchill says, success is not final. Failure is not fatal. It's the courage to persist that counts.
Thank you very much. Okay, let's take some questions from the audience. There's a question from Sonia Stokes. Currently, many hospitals and health systems are responding to smaller patient volumes by decreasing hours, shifts, and potentially even cutting the pay of emergency physicians. Many of us who work concurrently in public health see this as a dangerous decision, especially given we are still in the middle, or maybe even at the beginning of a pandemic. What policy changes would you recommend for hospitals and health systems regarding staffing that provide short-term solutions that are also not short-sighted?
That's a really terrific question. And I worry so much about this too. Just before this keynote webinar, I was just on the phone with some colleagues in primary care who work for community health centers. And it's kind of unimaginable, right? I think the general public even may not be aware that this is happening. I don't think they are aware. They see these images of frontline providers and think that, you know, they're calling providers heroes and saying that, oh, wow, you know, hospitals and healthcare is so important at this time. We're thinking about it all the time, but they're not aware that the very people they depend on now are actually potentially facing loss of jobs, loss of pay, and even closure in the case of these primary care health centers, potentially even closure of their health center that they normally go to for care. I mean, it really is, in a way, it's unimaginable, although we can see how this happened with the loss of revenue from elective procedures and other things. I mean, this is one where, in addition to what the hospital can do, we really need legislative change. We really, I mean, we need for the funds that come through to really prioritize our healthcare sector. Because I think exactly as the person who wrote the question said, if we are unable to sustain our healthcare infrastructure now, much less a few months down the line, what are we going to do when we have a second wave in the fall? What are we going to do even for all the patients who come in for non-COVID care? Because as we know, healthcare happens during a pandemic. You don't just stop requiring everything else. Even if there is a decline in volume for the short term, healthcare is still happening. So I think that, I mean, I'm not sure what the short-term solutions are for hospitals, because I think so much will depend on the dynamics and the finances of that particular hospital. But I do think that, to the point of the earlier question, this is where our voice in advocacy is so important. Frankly, right now, while we have the goodwill of our legislators, because people are saying, let's thank our providers. Well, let's show them that we don't just want, jets to be flying overhead. I mean, it's nice that people are saluting providers at night, but what we really need is to, first of all, have our personal protective equipment to keep us alive, and not endanger our families. And second, to keep our hospitals and our systems running so that we can continue to treat you into the future.
Thank you very much. Here's a question from Martina Caldwell. Do you see the role of public health evolving within emergency medicine specialty in the future, especially as COVID is currently ongoing?
It's a good question. I think there is growing awareness in the public of both of these fields, of emergency medicine and public health. And I think that, at least my view on this, and people may disagree, but my view on this, going through training and afterwards, was that it almost seemed like these were two totally different fields. As an emergency medicine was focused on the one hand on acute care, those like really downstream interventions, and public health was focused on the really upstream interventions on the other end. And they almost didn't overlap. But I think that there is growing awareness about how these two fields actually come together in so many different ways, again, because we are the front lines, because we do see the full spectrum of social determinants of health, because we are part of crises management all in different ways. I think there can be a lot more synergy and understanding. Frankly, I haven't thought ahead enough to know what that exactly might look like, but I do hope that this will spur more people to be interested in both of our fields, and potentially also in the intersection of these fields as well.
Thank you, that is great. Here's a question from Dan Meyer. You mentioned misinformation that has been happening. What is the public health answer to our fractured society and the all too frequent insertion of false science into the decision-making process?
Yeah, it's I'm going to answer this, but in a back to the first question that was asked about policy and advocacy as well, because it's taken me some time to find my voice, and the voice that I am the most comfortable with. In medical school, I was an advocate, and then of course I became a physician, and then was a writer, and then worked in policy, and then worked in government, and then worked in advocacy, and then came back. I mean, so it took me a while to find out what is that voice that I am the most comfortable with. And the voice that, and it's an evolving process, it might well change over time, and over my career too. But the voice that I am the most comfortable with speaking, especially at this time in our history, is as the voice of a physician whose information is based in, and advocacy is firmly grounded in science, evidence, and facts. And to that point, and to this particular question about what is our role and how we can do it, people can do it in different ways. I know that for myself, I want to answer the disinformation with facts. So as an example, I was on CNN actually right after President Trump made comments about injecting disinfectants. And I was on a panel where there were other people who were saying, who are political folks and advocates, who were saying things that were talking about what this means for politics, and you could imagine the partisan comments that people could be making. Yes, I could have added my voice to that, but I actually thought that where my voice is the strongest, and perhaps where many of our voices is the strongest, is to state the facts, to say unequivocally, do not inject or ingest disinfectants, because that will result in people getting very sick and could potentially die, right? I mean, we can speak and say, we have seen patients come into the EDs who have done these things, and it's obviously not a safe thing to do, and here's why. There are plenty of people who can speak with the political voice and say, and again, I'm not saying that these are wrong. There should be people speaking with whatever voice they want to use. And if that's the voice that you're comfortable with, that's fine too. But I think that one of the strongest counters to disinformation and myths and other things at this time is to be the credible truth teller. Think about Dr. Tony Fauci right now. He has the trust of the public because he is apolitical, because he is speaking with the voice of science and truth. When he doesn't know something, he says he doesn't know something. He's humble. He talks about he's very clear about what he knows, what he doesn't. And I think being able to speak with that voice of science and truth and evidence is what we have in our favor. And we should lean into that as a way to counter disinformation at this time.
Yes, very good point. Here's a question from Sarah Hawk. For emergency physicians with limited public health experience, can you recommend a starting point to help us gain appropriate experience to offer assistance to the public health organizations you suggested earlier could use our help?
That's an interesting question. So I actually think that you have a lot more public health experience than you know. Simply by being on the front lines and working essentially in the public health system, even though we don't necessarily call it that. I never thought about it in my training as I'm actually part of the public health system, but that's what the emergency department, for better or for worse, actually is. So I think you actually know a lot more than you may think. I mean, so much of the work that we do in public health, kind of the bread and butter of public health, are infectious illnesses and STIs. I mean, that's what we do in the EDs all the time. We do emergency preparedness and response. That's what we do in EDs all the time. I mean, so I actually think that you know and are steeped in it a lot more than you might think. I'm a nerd in some ways, and so love reading. I would recommend reading some good public health books. There was a book called Saving Gotham, that was written by the former health commissioner of New York City, who is now the health commissioner in Philadelphia. That's very good. There's the book that was written by the pediatrician who unearthed many of the problems with the Flint water crisis, Mona Hanna-Attisha. That's also very good. That what the eye can't see. I'm not Googling at the same time. And so, but Mona Hanna-Attisha's book and then the book called Saving Gotham, I think are great books that I think that people can relate to very easily. And I think that you can see also how your experience in emergency medicine really ties to public health. And then on the practical level, I would say, don't turn down opportunities to partner with your local health department or local community-based organizations. They will really want and need your help. And so feel free to offer your assistance. And I would also say, if you offer your assistance, don't demand a project. That was one of the issues that I had as the health commissioner, that I had many people come to me saying, I have this very specific niche expertise and I want to do a project in this. Well, I don't have time to be matchmaker for 100 people who may have great areas of expertise, but if I don't have that need right now, I can't use your expertise. And so I think if you approach your local health department or community-based organization offering to help in general with whatever they might need, I'm sure that they will come up with something, if not now, then into the future too.
Thank you. Very good advice. Here's a question from Chris Carpenter. You talked about patients being alone. Hospitals across the country have created no visitor policies for suspected COVID patients without exceptions. These policies are particularly detrimental for older adults with dementia who rely upon family caregivers to reduce incident delirium when hospitalized. How do you see this evolving in the future?
I mean, this is, of all things, is maybe the most heartbreaking part of COVID. I mean, people may have different thoughts about this, but I just can't really imagine. I think as someone who has gone through various end of life scenarios, I mentioned with my mother personally. Also, I recently gave birth. I have a 5-week-old, and so was in a situation where I was lucky. My hospital at the end ended up allowing my husband to be with me during labor and delivery, but I actually thought that it was possible to be without my husband during a trying time. This is not end of life, but it's also a trying time in people's lives. And I think a time when we could not have expected, who would have expected to be giving birth alone just a few months ago. And so, I mean, I have so much sympathy and empathy, I think, for people who are in this kind of situation now, as the patient, as the caregiver. I had co-written a book about patient advocacy, and one of the key principles is you should always have someone with you in that time, and to not be able to do that is, again, just unimaginable. Now, I'm not sure at what point our hospitals will be able to change that kind of policy. I imagine that having adequate PPE and having widespread testing, those are going to be important components to getting to the point that there can be someone who accompanies patients. We're not really there in either of those two standpoints. I could imagine too, potentially, if we have serological testing, if at some point we can confirm that immunity does in fact occur, I mean, I could imagine scenarios where this policy will change. But in the meantime, the advice that I've been giving patients, not just for end of life or anything, but just in general for patients, is make sure to come prepared with lists of your medications, your healthcare proxy information, your provider information. Make sure that you have your electronic device, and on speed dial, you can figure out very quickly and show you the providers who are there with you very quickly who to call to be with you while you're in the hospital. And I'm afraid that this is part of the new normal. That is just, again, one of the most heartbreaking things that we're living with.
Yeah, agreed. Very tough issue right now. Here's a question from Elisa Hayes. You talked about finding interventions when we can. What types of methods are out there, or can you think of, for community outreach to tell patients that coming to the ED is safe? What sort of communications do you think would work best for this, since many ED volumes are down quite low right now?
Our messaging at the beginning of this outbreak seems to have worked too well, because I remember at the beginning of COVID-19, and I did this too, right? I mean, when we saw that there would likely be very high volumes of patients coming in, we said to people, stay home. Don't come to the ED. Of course, we never said that to patients with acute issues, but we said, if you're not going to come, what I said was that if you're not going to come to the ED, if you were not going to come to the ED already, don't come because you want to get a COVID test, because you could be exposed to coronavirus there, because we're not going to get a test for you anyway, etc. And I think that as a result, we have a lot of patients who were potentially too scared to come in and get tested, understandably so, in part because of our messaging that we put out. I think that the messaging needs to be multiple components. I do think that we need to put out the messaging as much as we can in the media. We need to have trusted messengers put this out in the community as well. So again, community-based organizations, public health departments, and I think data will be helpful too. So if you can say, our average wait time used to be, I'm making this up, 3 hours, but now you can be seen in 20 minutes. I think if you wanted to do that, those types of data points will be useful in having patients have the confidence to come back. I do think that ultimately what will give patients the confidence to come back is actually the confidence of having COVID under control. And so the more that we can also talk about the protocols that we have in place to protect patients, and eventually, hopefully, actually getting the protocols or ensuring safety for patients too, I think that will also be important. So the messaging also accompanies the actions before.
All right, that is the last question we have time today. Thank you again to Dr. Wen for sharing your incredible stories and for helping the rest of the country prepare just a little bit better for the COVID-19 pandemic at their own hospitals and communities. Dr. Rothman, do you have any final remarks?
Yeah, so just a final comment. I just wanted to thank Dr. Wen. When I asked her if she would do this presentation, she jumped immediately. And I think she gives a great message of courage, leadership, and optimistic vision for the society. Her vision strongly echoes that of another leader, Barack Obama, and basically saying that as emergency physicians, we can't wait for another person or some other time to make a difference. We have to recognize within ourselves, both individually and as a collective, that we're a path forward for responding, and that we can and will make a difference for navigating that path forward, both for our patients and for the health of the public. So thank you so much, Dr. Wen. We really appreciate and value all of your insights and optimistic vision forward.
Thank you very much, Dr. Rothman.
Thank you again to Dr. Wen and Dr. Rothman. We truly appreciate your time. And now we are going to jump right into our next presentation on diagnostics. For those of you who are just now joining us, I am Dr. Jim Holmes, president of SAEM. SAEM is the premier international organization representing researchers and educators in emergency medicine. In our work, SAEM promotes and facilitates scientific discovery, educational innovation, and the professional and leadership development of our members. Today, we are proud to bring you a special session on COVID-19 diagnostics, the presentation entitled Diagnosis of SARS-CoV-2, an Update. During this presentation and during our question and answer session, you will hear from Dr. David Persing, Executive Vice President, Chief Medical and Technology Officer, Cepheid. He will share his experience with the COVID-19 pandemic, providing along the way guidance and insight that will likely prove invaluable to the rest of us as we care for our patients in our EDs. During the presentation, you may submit questions for the presenters by clicking the Q&A button in your Zoom menu interface. Questions that are upvoted will be prioritized during our question and answer session to start immediately after our presenter has concluded. We also want to recognize a couple of experts that are joining us online behind the scenes and will be helping to answer questions throughout the presentation. We have Dr. Patrick Mahar and Dr. Dennis Shia. Thank you all for your time and expertise. It is greatly appreciated. To begin, I'd like to introduce again Dr. Rich Rothman, SAEM's COVID-19 Planning Chair, to provide the opening remarks. Dr. Rothman is the Executive Vice Chair in the Department of Emergency Medicine and Professor of Emergency Medicine at Johns Hopkins Medicine. Welcome again, Dr. Rothman.
Thank you, Dr. Holmes, and thank you again to SAEM for hosting today's special address. Soon you'll hear from Dr. David Persing, who is the Executive Vice President and Chief Medical and Technology Officer at Cepheid. Dr. Persing was appointed in 2017 as the Chief Scientific Officer for Danaher Diagnostics platform. He spent most of his 25-year career in biomarker discovery, translational medicine, and innovation in the diagnostic space. As the Chief Scientific Officer for Danaher Diagnostics, he has the responsibility for providing scientific, medical, and strategic input to the diagnostics operating companies and platform leadership. He also has responsibility for development of new clinical processes, technologies, or products that advance patient care and innovation as part of the diagnostics group of operating companies. Dr. Persing joined Cepheid in 2005 and has focused on the enablement of molecular diagnostic technologies to meet global needs in infectious diseases. He's conducted his scientific medical training with Dr. Don Ganem and Nobel laureate Harold Varmus at the University of California, San Francisco, where he earned his MD and PhD. Since completing his residency training in clinical pathology at Yale University, Dr. Persing has held leadership roles in both academia and industry, beginning in the early 1990s with the design, implementation, and operation of the first PCR reference laboratory at the Mayo Clinic. His interest in the democratization of molecular diagnostic methods has been longstanding, starting in 1993 with his first publication of the original widely adopted textbook, which included PCR protocols and guidelines for laboratory operations. Dr. Persing has published over 300 peer-reviewed articles and reviews, including multiple articles in the New England Journal of Medicine, Science, and PNAS, and he's also served as editor-in-chief of 5 highly regarded textbooks, the most recent of which was published in 2016. In order to maintain a connection with the latest trends in translational medicine, Dr. Persing also currently serves as a consulting professor of pathology at Stanford University School of Medicine. Over the past few months, Dr. Persing has played a leading role in helping develop and mobilize molecular testing capacity across the US and was responsible for development and deployment of the first FDA-approved point-of-care COVID-19 test here in the United States. We're happy to have him here to join us to share his experience and expertise with us in the midst of this evolving pandemic. Thank you, Dr. Persing.
Wonderful. Thank you, Dr. Rothman. With that said, Let's welcome Dr. David Persing. Dr. Persing, thank you for joining us today. We are very appreciative of your time and we look forward to your presentation. The floor is now yours.
Okay, thank you for the introduction. I'm happy to be here. Just wanted to give a brief mention that, in fact, I really appreciated the mention in the last presentation about making the invisible visible, because in fact, that's what we do in vitro diagnostics. We make the invisible visible. And I think that's really playing an incredibly important role right now in the management of COVID because of the way patients present. Sometimes they can be asymptomatically infected, and it's critical for in vitro diagnostics and diagnostic approaches to make the invisible visible in these scenarios in order to really understand the disease better and to understand transmission risk better. This is a snapshot of the Johns Hopkins dashboard for cases as of last Monday, and the number, as you can see, is rising rapidly. Number of deaths is now higher than some of the earlier estimates that were probably too conservative. We've pushed above 80,000 deaths in the U.S., and so it's not going away anytime very soon. Next slide. The culprit here is a new coronavirus. It's called SARS-CoV-2. It is an interesting virus. It's zoonotic, which means it has its origins in other animals. The first reported case was on December 12th in Wuhan, China, although there are reports of potential earlier cases than that in November, possibly even October. But the first reported case was on December 12th. We know coronaviruses in our recent history because of the SARS outbreak and the MERS outbreak, both of which occurred in the past 18 years, over the past 18 years, starting with SARS coronavirus, the original SARS coronavirus in 2002, and a MERS coronavirus outbreak in 2012. But we also know that coronaviruses can cause common cold symptoms. And there are 4 major strains in circulation that produce seasonal presentations of often and probably usually non-febrile presentations of the common cold. And these have an interesting history, which I'll talk about in a minute. Next slide. So if you look at the genetic relationships of different coronaviruses, you see some interesting patterns here. There are 4 different families of coronaviruses: alpha, beta, gamma, and delta. The beta coronavirus family is the most diverse in terms of having the most branches and offshoots. And these largely relate to the animals that they have come from and the animal reservoirs that they have come from. And they also contain, the beta coronavirus family contains the current coronaviruses of pandemic concern or epidemic concern. SARS, the original SARS virus, SARS-CoV-2, the current virus, and the MERS family of coronaviruses. And a fair amount is known about the animal reservoirs of MERS coronavirus, but we're still trying to understand the origins of SARS coronavirus and SARS-CoV-2, although we strongly suspect that they have originally a bat origin. The bat was the original source of both the original SARS strain and SARS-CoV-2. Next slide. So looking at the seasonal coronaviruses, there are 4 major strains, as I mentioned. It's the second most common cause of upper respiratory infections after rhinoviruses. They are clinically very difficult to distinguish from rhinovirus infections. Interestingly, these strains probably, I'll take the next slide, probably entered the human population starting back in the 1100s with the introduction of coronavirus NL63. So the 4 strains that are now endemic that cause seasonal coronavirus, seasonal common cold symptoms, probably entered originally as pandemic strains and then adapted over time to become less pathogenic. And so they're NL63, 229E, OC43, HKU1. These are now in circulation as seasonal coronaviruses, not very pathogenic, but they probably took a leap from their original animal sources as far back as the 1100s. How do we know this? Well, there are ways to do sort of molecular clock analysis in viral evolution. And if we look at the rate of change over time in the viral genomes, it allows us to project back in time to the closest relative in nature that we know of now. And so based on these molecular clock analyses, we think that the first entry of a seasonal coronavirus happened back in the 1100s, possibly from a bat origin. We think that 229E may have come through a camel intermediate host, originally from a bat. OC43, not clear bat origin, but it's also a beta coronavirus. It may be traceable to ruminant sources. And then, of course, the Wuhan coronavirus, we think originally came from bats, may have had an intermediate host, and then made the leap to humans. So next slide. So SARS and MERS are the most recent coronaviruses prior to this one. And we've learned a lot about the pathogenicity and the transmission pathways of these viruses over time. But they are only partially predictive of what is happening now with the current coronavirus. The original SARS coronavirus in 2002, we think made the jump between bats to civets, which is a cat-like animal, and into humans. And it produced a local outbreak that actually went international into sites outside of China, produces outbreaks in Canada. It had a very high case fatality rate of around 11%. And so much higher than the current case fatality rate for the current coronavirus, SARS-CoV-2. MERS actually has a higher case fatality rate. It emerged in 2012 in Saudi Arabia. It comes from exposure to camels. Camel spit, camel urine can lead to transmission. So be careful next time you take a camel ride in the Middle East. That's where it comes from. It's produced regional epidemics, regional outbreaks, but not widespread international outbreaks, but has an even higher case fatality rate of 34%. Next slide. So I was asked by Rich to talk about the laboratory diagnosis of SARS-CoV-2, and I'm going to be touching on serology, antigen detection, and nucleic acid amplification tests as 3 different approaches. I will not be talking about viral culture or antibody neutralization assays, which are also laboratory techniques, but not commonly implemented or widespread. So the tools that we have currently available for making the diagnosis in the emergency department at the hospital level include serology, antigen detection, and nucleic acid testing. Next slide. So starting off with serology, what's the utility of a serologic test in diagnosing coronavirus infection? One of the original findings in studies in China was that when molecular methods from various upper respiratory sites when results from the early PCR studies were completed, they were finding a relatively high rate of false negatives as defined by SARS-CoV-2 case definition. So these were patients who were almost certainly SARS-CoV-2, but coming into the hospital when respiratory samples were taken from the upper respiratory tract or the oropharyngeal area, they were sometimes negative. And in fact, false negative rates as high as 30% were seen in some studies in China. And so there's been an interest in complementing this false negativity of molecular methods with serologic methods. And the first point I will make, though, is that many of these early studies were based on molecular tests that were not very sensitive. They were widely available in China early on as a very strong participation in commercial supply of various PCR kits, but they were not all validated methods. And when more sensitive PCR methods were used, the false negative rate dropped dramatically. And I would say in the US, with the currently available molecular approaches in general, especially the ones that have been validated for their sensitivity, the false negative rate of molecular methods with a well-collected specimen, and I'll talk about that in a minute, with a well-collected specimen and a sensitive molecular test, the false negative rate is much lower. Recent studies at Stanford suggest that it's maybe closer to 5% than 30%. So the driver to complement molecular methods with a serologic method based on clinical suspicion is, I think, should be lower. And we'll look at the role of serology in acute case management and also in follow-up testing in a little bit. It's also going to be useful for identifying convalescent plasma donors for potential plasma therapy in the future. We need to know what the seroprevalence rates are in the population to know what our level of potential existing protection might be against future challenges or exposure overall. We're going to be looking at seroconversion as a function of vaccination. And some countries have talked about using serology as sort of a COVID passport. So if you're IgG positive and your IgG response is characteristic of a neutralizing antibody response, as will be characterized for many serologic methods, then there's talk about the possibility of using this as sort of a passport for allowing people to go back to work or to re-enter relatively high-risk areas with lower risk of disease transmission in seropositive individuals. This is still very much a work in progress, and we're still struggling to define what that looks like in the US because of the just very recent implementation of serologic methods. But the challenges are that these tests are not really very useful for acute diagnosis. There are too many false negatives to be practical in terms of making the diagnosis. And because of the lower false negative PCR rate with newer methods on well-collected specimens, the need for them in the acute setting, I think, is diminishing. And this is largely related to the fact that it takes a while for antibodies to develop in this condition, especially if the condition is mild or asymptomatic. It takes a long time for antibodies to develop. There's also a big problem, especially with the lateral flow technologies, the rapid antibody tests with false positives, because these tests tend to cross-react with rheumatoid factor, which is a common confounder of IgM-based serologies, and also possibly with other coronaviruses, including some of the endemic coronaviruses. So cross-reactivity is a problem, and you'll see in a minute that, in fact, that has been documented with many of the lateral flow immunoassays, which makes them less useful because in many places, the rate of false positives on those assays may well exceed the actual number of true positives in many settings where prevalence is low. So next slide. And just for your information, I've attached the references to each of the studies that I'm citing and the references to some of the information being shown in the slides. Those are at the bottom of the slide deck. So if you want to look it up and read it in detail, it's available to look at. Most of the immunoassays now are based on two proteins. There are other proteins that are being looked at, but the widely available immunoassays are based on either nucleocapsid on the inside of the virus that wraps up the nucleic acid, or on the spike protein. The spike protein's on the outside of the virus, and in fact, it's the namesake for coronavirus because it gives the virus a crown-like appearance with all the spikes on the outside. There are two major formats of this, lab-based immunoassays, fluorescent immunoassays, enzyme-linked immunoassays. These methods are proving to be the most accurate. They have the highest sensitivity and, importantly, the highest specificity. They're not confounded by cross-reactivity with other coronaviruses or as much by rheumatoid factor. The lateral flow immunoassays are fast, but they're quick and dirty. They have problems with both sensitivity and specificity. In general, antibodies are reliably detected in 10 plus days post-symptom onset. So given the fact that the average incubation time for this infection is around 5 to 6 days, with 95% of patients experiencing symptom onset within 12 days, it just takes a long time post-exposure to seroconvert, and thus they're not that useful in the acute setting. Next slide. This is some of the data that's coming out of these seroconversion studies. On the left is a JCLIN micro paper showing antibody responses to nucleocapsid at the IgG and IgM levels, and antibody responses to the recombinant spike protein on the right side. And you can see they look pretty comparable. The recombinant spike protein may have a little bit of a sensitivity advantage because it may be an earlier response, but in both cases, it takes about 10 days before you see a majority of cases that have seroconverted, and about 17 days to get the vast majority of individuals in case-defined COVID to be detectable by IgG responses. IgM responses generally, as you may know, in the literature are the first antibody class to develop in response to a new infection. But ironically, there hasn't been as much of an advantage, a time advantage for IgM in many of the serologic tests that have been looked at right now. And we don't really know why that's the case. Typically, you get a much earlier IgM response than IgG, but most studies are showing that they come up about the same time. And this is evidence in this study, and many other studies are now being conducted. A very good paper on the indicated on the right side is a study published in Nature of the natural history of coronavirus infection in cohorts of patients in Germany, where they actually did molecular testing, they did serologic testing, and they also looked at recovery of live virus from patients during the course of infection. And what's interesting about this is that the number of positive cultures drops off dramatically with seroconversion. So patients may still be PCR positive at time points. You can see at the bottom the days after onset, they may still be PCR positive at day 10, for instance, and their seroconversion may be close to 90% at that time, 85 to 90%, 100% by day 14 in this study. But their rate of recovery of virus seems to drop off after the major inflection point for seroconversion. So this would suggest that they are developing neutralizing antibody responses that are preventing the virus from being recovered in culture. Studies like this need to be conducted for us to fully understand the relationship between seroconversion and virus neutralization. And it'll be important for us to be able to interpret our PCR results, especially in patients with prolonged viral shedding, in light of the seroconversion data to know who is at risk for further transmission. Next slide. So we also have found in the literature that, and in published literature, is that the level of the serologic response, again, against either the spike protein or the nucleocapsid protein, or at the level of virus neutralizing antibodies, is relatively delayed in patients who have a milder course. So this has been a consistent finding. The more severe the infection, the greater the inflammatory response, the greater the recruitment of immune response cells, T cells, macrophages, et cetera, to the site of infection, and therefore the more efficient seroconversion in more severe cases. Whereas cases who are milder tend to have delayed responses, and we really don't know what the kinetics are like in patients who were asymptomatically colonized with coronavirus, but it's likely they're going to take longer to develop antibody responses than a patient who presents with more severe symptoms. Nonetheless, all the patients in these studies so far have seroconverted, whether mild or severe, but between 13 and 21 days after onset of symptoms. So it might be the case that asymptomatic carriage might take a little longer than that, but nonetheless, it seems likely that even those asymptomatic carriers will eventually seroconvert. Next slide. So a lot of the assays are being developed on the basis of spike proteins and nucleocapsid proteins. This is a structure of the spike protein that you can see, and there's the green box there is called the receptor binding domain. That can be expressed efficiently in recombinant form for the immunoassays to be developed. On the left side of that box, picture of the protein, is the SARS-CoV-2 specific domain. On the right side, and the so-called S2 domain of the protein, those parts of the protein are less specific to SARS-CoV-2, and so there's a greater potential for cross-reactivity with seasonal coronaviruses, and that's what you really don't want in a serologic test. You want it to be specific for SARS-CoV-2. And so most of the immunoassays in development now include proteins on the left side that are more SARS-CoV-2 specific. Next slide. And this is borne out by the studies so far. There's a little bit of cross-reactivity between the original SARS virus and SARS-CoV-2 with the spike protein immunoassays. This is not really a practical limitation because the original SARS virus from 2002 is not in circulation. So even if there is a little cross-reactivity with that virus, what matters is that it doesn't cross-react with seasonal coronaviruses that are not SARS related. And the potential sensitivity advantage of using the spike protein, I think, could still be put to good advantage here, even with that limited cross-reactivity with SARS-CoV, sorry. Next slide. Recent study from University of Washington group in a patient population in Idaho, where the prevalence is relatively low. They were specifically interested in looking at the specificity of these assays to see if in a low prevalence population, there was a problem with false positives, which is a bigger problem in a low prevalence population than it is in a high prevalence population. And so they looked at different levels of specificity applied to the test from 99% to 99.9%, on the assumption that if you test 1,000 people, that one false positive in 1,000 might be an acceptable level of specificity when your rate of infection is low. And so they looked at different levels of specificity, and then looked at sensitivity performance at various time points after onset of symptoms from day 7 to day 17. And what they found was that at a specificity threshold of 99.9%, 1 in 1,000 expected false positives, that the sensitivity came down a little bit depending on the time-dependent course of seroconversion. But even at day 7, they found that 84% of cases were seropositive with essentially 100% specificity. So this is encouraging because it means that we don't have to deal with these next-gen laboratory-based immunoassays that run on big systems found in clinical chemistry and clinical immunology labs throughout hospitals in the country. These big systems will be capable of delivering accurate results that have low false positive rates and with reasonable specificity, but still not where you'd want them to be to make a diagnosis of an actively symptomatic patient presenting for the first time because of the lag time between initial presentation and seroconversion. Next slide. I mentioned rheumatoid factor. Rheumatoid factor is an anti-IgM antibody, which actually can interfere with a lot of immunoassays. And by using special techniques to essentially wash off these low avidity antibodies that don't bind very tightly to a target, but they produce non-specific binding problems, we can distinguish with some of these central lab immunoassay platforms, we can distinguish rheumatoid factor from true antibody responses by carrying out these washing steps. This is not a feature of lateral flow immunoassays. They really can't do this with the rapid fingerstick blood-based immunoassays. So they will struggle with rheumatoid factor and cross-reactivity depending on the test. Next slide. This is a study that was published recently from UC San Francisco. And on the right side, you see different lateral flow immunoassays that usually run from fingerstick blood. And what you see in the panels is the performance of these assays, percent positivity from 1 to 5 days, 6 to 10, 11 to 15, and beyond. And some of them performed poorly across all time points. All of them improved in sensitivity as time went on, but very few of them performed very well in the days following clinical manifestation of infection. So you can see that even with combined IgM and IgG in the middle panels, that the sensitivity did not exceed 50% in the 1 to 5 day period. It got a little better from 6 to 10 and beyond, and got close to 80 to 90% sensitive in the convalescent phase of these infections. But on the right side, you can see the specificity of these tests when run in populations of patients pre-COVID in San Francisco. So before any exposure to the virus, they included serum banks from people who, which were available prior to COVID, that the IgM and even IgG responses had relatively high false positive rates, ranging from 5% to as much as 8% false positives for IgG, and as much as 15% false positive rates for IgM. So this is higher than the presenting rate of infection in presenting patients in many medical centers. So you could expect that if you use this test for the acute diagnosis because you didn't trust your PCR, that you'd expect to see a lot of false positives. And these would have to be resolved later with a big box immunoassay platform that would be run in the central lab. Next slide. So interpretation of these results: IgM negative, IgG negative, no evidence for prior exposure, except lateral flow tests. You might see false positives with IgM. So I'm really restricting my comments now to the next gen serologic tests, which don't have false positive problems. And I mentioned about delayed seroconversion. If you're still concerned about active infection and the patient is totally antibody negative, then PCR is recommended, or a nucleic acid test recommended for ruling out active infection. IgM positive, IgG negative could be an indicator of early infection, especially if it's a next gen assay that doesn't have false positive problems. You could expect IgMs, even with those next-gen assays, to have higher rates of false positivity because IgM antibodies, by their nature, are less specific for the target and don't have high affinity for the targets. And so cross-reactivity rates are expected to be higher. In that case, PCR will be recommended for ruling out active infection. Next slide. I think I may have skipped a slide there. There was a second. Okay, I'll just go on to the next slide. So the bottom line from serology is that it's going to be useful for epidemiologic tracing, understanding population risk. It's not that useful for the acute setting. The message that you may hear from aggressive point of care antibody marketing companies is that it's because PCR is so insensitive that you need this. But actually, I think current PCR practices, especially in the US, are such that with most of the assays out there, that we can depend on those results better if the sample collected is a good specimen. So combination of good specimen and good PCR test, good nucleic acid test will result in very low false positive rates based on what we're seeing so far. Antigen testing, recent announcements from a couple of companies on antigen testing. We know based on flu testing that the rapid antigen tests for flu are, at least on a limit of detection basis, are about 1,000-fold less sensitive than molecular methods. And antigen testing is quick, it's relatively inexpensive, but it doesn't have the same sensitivity of a molecular method. It might be okay for an acutely ill patient with high clinical suspicion in a point of care setting, but you're still going to have false negatives just based on the analytical sensitivity differences between molecular and protein-based antigen detection. So it might be okay for identifying supershedders when you have a perfect specimen from a supershedder, but in sort of clinical actual life in a clinic where sample collection might not be perfect, might not get actually all the way back to the posterior nasopharynx, and where you have less than perfect um, conditions of operation of the test, then it might not do as well. Thank you. Next slide. A nucleic acid amplification test. This is the final area I'll talk about and then finish up with a couple of notes. The nucleic acid amplification tests that are available now represent a combination of central lab, reference lab tests, central lab tests that are often now run in hospitals, and a few point of care offerings as well. The targets used for these tests vary widely. In some tests, there are 2 targets included to avoid the potential for genetic drift of the virus as it mutates. We don't want the virus to mutate away from being detectable. Some assays have 1 target, some have several targets, some have broad range targets that will cover other members of the SARS bat coronavirus family. Some are very strain specific. But in general, I would say the state of the art for nucleic acid testing is such that the major commercial suppliers of nucleic acid tests from the major manufacturers, along with the reference lab methods that have been developed, even though they're laboratory developed tests and may not depend on a commercial manufacturer, are performing at a good level. Next slide. Some of the data coming out of that paper I mentioned from Germany shows some of the PCR data. This shows the tracking of PCR results in stool, sputum, and oral swabs over time after symptom onset. So you can see that in sputum, especially in patients with lower respiratory symptoms, there tend to be pretty high levels of virus, and it takes longer to clear. In oral swabs, the greatest utility of these swabs appears to be within the first several days after symptom onset. So in this patient case study that they presented, when the patient had a cough, they were able to readily detect it in sputum and an oral swab, also in stool. Importantly, you can see that there was a seroconversion point here with the arrow at around day 9 when they first saw antibody. When they went back to culture virus from the stool and other samples from this patient, the cultures began to become negative. And they were never really positive in stool samples. So there's controversy about what a stool PCR really means. We know you can detect RNA in there, but we're not sure about whether it really represents an infection control risk, especially after seroconversion in patients who are in the convalescent phase. Next slide. Many of these tests have gotten emergency use authorization, and many of the so-called drive-through options that you see out there are run on reference labs, either on a commercial platform or a laboratory developed reference lab method. These are typically run in batches. So you collect the specimens in batches, you wait for a batch of swabs to justify shipping, you send the batch specimens to the lab, they're batched in the lab. And depending on the test, in a reference lab setting, you can expect results in 2 to 7 days, although I think that that's getting faster now because of the increasing testing capacity. But 2 days is a realistic turnaround time from a reference lab. What's happening now is we're seeing a lot of commercial systems that are already in hospitals, Roche, Abbott, Hologic, BD, Thermo Fisher, Diasorin. These are increasingly available at the local hospital level, so they're closer to the patient and the results can be faster. And so this really depends on the shorter transit time of the specimen to the lab. They're still batched, but the results are faster because batches are being run frequently. These are not generally available in small to medium-sized hospitals, and they all require trained staff and staffing of these systems around the clock has been a real challenge in the current situation. Next slide. There are some sample to answer NATs that are available from the Expert, the ID Now system from Abbott, and the ePlex system from Genmark. These have been compared in one study just published, and they range in sensitivity. Next slide. Their analytical sensitivity is also variable. So the number of copies of RNA it takes to trigger a positive result varies widely between these point of care options. I would say in general, though, most of the central lab methods and reference lab methods are in the 100 to 200 copies per ml range for limit of detection. So central lab testing is generally, I think, sensitive enough to be used as a gold standard method. Next slide. There are very few studies actually comparing platforms against gold standards. And part of this is because the emergency use authorization process for getting these tests on the market did not require an actual clinical trial. So Cepheid has performed a multi-center clinical trial. Other companies have done that. And we're seeing more and more studies now comparing different platforms in actual clinical specimens prospectively. And so this is very helpful to judge the performance of these tests and how they'll do in real life. And this study was just published, data is available, and against the gold standard of the laboratory developed tests, the public health lab tests, and other commercial tests, the level of performance was highly concordant. Next slide. Specimen collection matters. As I mentioned, it really does matter here. There's a lot of interest in avoiding false negatives because of a bad specimen. And I mentioned about the high false positive rate, high false negative rate in China. Part of this may relate to the fact that in China, they like to favor oropharyngeal swabs and less nasopharyngeal swabs for largely cultural reasons. And this leads to the fact that you can't get the site with the highest viral load into the test, and this may lead to a higher false negative rate. As I mentioned, the Stanford false negative rate is reportedly less than 5%. This is based on nasopharyngeal swabs being tested with a sensitive method. And I think that combination will lead to low false negative rates overall. Combining swabs, oropharyngeal and nasopharyngeal, into the same transport medium, I think could result in less sampling error, where you might miss the site of replication by combining anatomical sites in one sample. And data suggests that when you combine the swabs from two different sites, you may get better performance. Next slide. Which specimen is best? In general, nasopharyngeal is more sensitive than nasal swabs. The viral loads are higher. When compared against oropharyngeal swabs, a little bit better performance than oropharyngeal, better than nasal. But we all see that in sputum aspirates that that performance overall is high because of high titers in these specimens. A lot of interest in saliva testing. This could reduce biosafety risk during collection. It could be collected at home potentially by the patient, self-collected, not swab dependent, can be self-collected. So, and when you think about it, this could be a naturally pooled specimen, especially if it's a deep throat cleared saliva specimen. I used to say in junior high, haka loogie, right? Clear your throat, pool the specimen in your mouth and spit it out. This appears to be a way to sample the upper respiratory tract as well as the oropharynx in one collection process. So this may be a specimen we use going forward as a sort of a naturally pooled specimen to cover different anatomical sites of replication of the virus. Next slide, next slide. And this just shows some of the data on saliva. It looks actually pretty promising. And so a lot of the test manufacturers are now validating saliva as an alternative, especially in the age when it's hard to get swabs and hard to get viral transport media to do the test. This might be a nice alternative to be able to provide for specimen collection. Next slide. And it looks like actually there's more human DNA on board in saliva than there is in NP swabs, suggesting that the number of cells sampled that could be replicating virus might represent an advantage in terms of just getting more stuff into the final reaction. Next slide. What about asymptomatic carriage? A small study done at University of Washington, nursing home residents showed a pretty high rate of asymptomatic carriage in a nursing home. Over half of them were asymptomatic with pretty low cycle threshold values or pretty high viral loads. 10 of them developed symptoms within 1 week. They really didn't see any differences between symptomatic and asymptomatic cases in a nursing home setting. They also showed that these asymptomatic cases were all, in a later publication, showed that they were culture positive when they were asymptomatic. So this represents a significant source of transmission pressure in these group congregate living situations. Next slide. Stanford recently did a study of about half of their healthcare worker population at Stanford Medical Center. They did over 5,000 PCRs. They found a 0.4% positivity rate, which I think is lower than they found at Rutgers, with about a 7% positivity rate at Rutgers. Low positivity rate at Stanford, but some of the viral loads in some of the individuals or carriers were on the low side, which are on the high side, cycle threshold values on the low side, suggesting they might have been capable of transmitting from those cases. They also saw the first RNA positive blood donor at the Stanford Medical Center, last symptomatic in mid-March. They were antibody positive. Their plasma was positive for 2 targets, and that donor is being tracked. But this could be a new source of transmission potentially in immunocompromised patients if blood donor screening is not implemented widely in the future. Next slide. Pooling might be able to increase throughput in our testing by combining transport media into one sample and testing the pool. If you have a very sensitive PCR test, you might be able to actually do a lot of people with a relatively small number of tests. Stanford did this for looking at respiratory samples in the January-February timeframe before COVID in Santa Clara Valley. They pooled the samples into pools of 10, I believe, and they went back and deconvoluted those pools to find 2 positive patients in that timeframe. So not very many cases being transmitted in the months prior to the official onset of COVID. This could be a potential approach to asymptomatic screening in lower prevalence populations, which is being looked at. Next slide. To conclude, I want to give some time for questions. I'm sorry I haven't left more time, but serologic methods are rapidly evolving, not really helpful in the acute management stage. Most of the combinations of results need to be reflexed to a molecular test anyway in the acute phase of patient management. Lab-based methods for viral serology are vastly superior to lateral flow at this point. Nucleic acid tests are the gold standard. Most of the tests on the market from most of the manufacturers and most of the reference labs are up to snuff in terms of sensitivity. But these tests are only as good as the sample that's collected. So garbage in, garbage out. If it's a bad specimen, you will not get an accurate result. So pay attention to getting good specimens. Watch for the flinch sign from patients getting nasopharyngeal swabs. They're going to flinch. I like to say for a child, you have a single lifetime opportunity to collect a nasopharyngeal swab. You will never get another one again. But I can say also that's probably true for a lot of adults. So got to have a flinch, got to have tearing to indicate that you've had gotten to the site of collection. And it's challenging enough right now outside of the respiratory season. We need to prepare ourselves for what we're going to do in the upcoming respiratory season. And I think it's good to think about that now in terms of how we manage these patients, what tests we run, how do we distinguish them clinically with laboratory methods. And I think that's going to be a big challenge in the upcoming respiratory season. That's all I had to say. Thanks.
Thank you very much, Dr. Persing, for this timely and insightful presentation. We will try to get as many questions as possible in our remaining couple of minutes. So while the questions are coming in, let me ask Dr. Persing, will we see testing widely available that would allow us to immediately screen people to meet in large groups? For instance, weddings, sporting events, academic meetings like we are having right now.
It's a very good question. There's a lot of discussion about that right now. I'd say right now, there's a lot of interest in asymptomatic testing, but that focus is primarily on the go back to work strategy for hospitals. It's based on pre-screening patients for elective surgery, healthcare workers, labor and delivery, incoming admissions, for looking for asymptomatic carriers in that setting. I think eventually we're going to see this branch out into like testing nursing homes and healthcare staff in nursing homes, and then maybe move to testing essential workers in other industries. From there, I think we will eventually see more widespread implementation of screening methods, possibly on larger populations, perhaps using a pooling strategy, which could screen a lot of people with a relatively small number of tests. But that all remains to be shown whether we can do that effectively.
Thank you very much. A question from Jonathan Rubin. How much does creation of assays under the Emergency Use Authorization Act affect test accuracy?
It's a good question. I think the amount of proof required to get an emergency use authorization depends primarily on mock clinical specimens, where you take nasopharyngeal swabs and you spike virus onto the swabs and detect the virus at different concentrations. None of the EUAs have had to depend on any kind of clinical trial evaluation. So the actual performance in the field is not really known very well. It's just coming out in the past couple of weeks in some of the studies that I cited. So it remains to be seen which ones of these will work or not work based on prospective data collection of head-to-head comparisons. But right now, the threshold for emergency use authorization has been focused on expediency and getting as many options on the market as possible, and hoping that the data coming back will allow for better understanding of how they're actually performing.
Thank you very much. A question from Michael Brown. You mentioned that the false negative rate is likely only 5% in US-based studies. What is the gold standard used to determine the sensitivity of these PCR tests?
The gold standard in that case, and I think that in most centers, is a clinical diagnosis, which often depends on a clinical presentation characteristic plus a series of tests applied to a patient over time. So for instance, a patient may come in respiratory distress, they get admitted, their nasopharyngeal swab is negative on admission, but their tracheal wash is positive. And that composite definition of a case over time after admission is what goes into the gold standard diagnosis. And so we're finding that in general, there are cases where the virus is no longer present in the upper respiratory tract, and it's now concentrated in the lower tract. Those are the cases we will miss with just respiratory tract sampling. And so there is some I think still low probability of that, even with sensitive methods and a good sample. So it's not non-existent, but I think that ultimately the case definition with supporting laboratory and other clinical evidence is what the gold standard should be used, should be in that setting.
All right, thank you very much. Unfortunately, that's the last question we have time for today. Thank you again to Dr. Persing for sharing your incredible stories and for your helping the rest of the country prepare just a little bit better for the COVID-19 pandemic at their own hospitals. Dr. Rothman, do you have any final remarks?
Thanks, Dr. Holmes. There's obviously been a tremendous amount of research in this space in the past 2 months, and I just wanted to personally thank Dave, Dr. Persing, for consolidating and sharing this in a unified format for the SAEM audience. Very much appreciated. I know how busy you are, and I think it's extremely valuable. And I'd just like to end with a call for the academic emergency medicine community to continue to play an active role in research through collaboration. I think we have an important function here that's going to help inform how we deploy these tests in practice, and that will end up having a big impact, I think, over time for patient care decisions in the emergency department and for the health of the public. So thanks again, Dr. Persing, very much appreciated.
Thank you very much, Dr. Rothman. Thank you again to our speakers and to all of the viewers for joining us today. We look forward to seeing you tomorrow for our next keynote address on medical education and our COVID-19 special session on therapeutics. Stay safe and have a good day.